If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. In today's episode, we look at the NICE updates published in November 2025, focusing on what is relevant in primary care only. And this time, we have had 3 brand new guidelines on a single topic, sepsis. There are 3 separate guidelines because each one focuses on a different group: people aged 16 and over, children and young people under 16, and those who are pregnant or recently pregnant. Right, let's jump into it. And we will start by saying that we will focus on the recommendations for people over 16. But I will also point out what's different for the under 16 group and for pregnant people. If infection is suspected, the first question to ask ourselves is, could this be sepsis? And then assess for a potential source, for risk factors, and for any signs of clinical concern in circulation, breathing, or behavior, ideally using a structured system. The main 6 observations that we should assess are temperature, heart rate, respiratory rate, blood pressure, level of consciousness, and oxygen saturation. However, we need to remember that some groups of people with sepsis may not develop a raised temperature, and that, in terms of oximetry, poor peripheral circulation due to shock can make peripheral oxygen saturation difficult to measure. Additionally, we need to be aware that some pulse oximeters can underestimate or overestimate readings, especially if the level is borderline, and that overestimation has been reported in people with dark skin. Additionally, we should examine for mottled or ashen appearance, cyanosis, skin rashes, particularly non-blanching petechial or purpuric rashes, and any breach of skin integrity as a source of potential infection. We should always keep in mind groups who are more vulnerable, that is, people over 75, those with frailty or comorbidities, learning disabilities, immunosuppression, indwelling lines or catheters, recent surgery or invasive procedures, and those with adverse social or economic factors that may delay presentation. In hospital or ambulances, the National Early Warning Score 2 or NEWS2 is recommended. NEWS2 measures the same 6 values: temperature, heart rate, respiratory rate, blood pressure, level of consciousness and oxygen saturation, and then give points based on how abnormal they are. I will not go through every score and its clinical implications, but there's a NEWS2 calculator app reproduced from the Royal College of Physicians that I would really recommend downloading. However, in primary care, we can consider NEWS2 or any other structured tool. The guideline gives us a set of criteria to assess the risk of severe illness. There are high, moderate, and low risk criteria. The high risk criteria for people over 16 are as follows: a new altered mental state, a respiratory rate of 25 breaths per minute or more, new need for oxygen to maintain saturation more than 92% or more than 88% in chronic hypercapnic respiratory failure, a systolic blood pressure of 90 mm of mercury or less, or more than 40 mm of mercury below normal, a heart rate of more than 130 beats per minute, no passing urine in the previous 18 hours, or for catheterized patients passing less than 0.5 ml per kilo of urine per hour, mottled or ashen appearance, cyanosis, and a non-blanching petechial or purpuric rash. These are the high-risk criteria only. For simplicity, I will not go through all the moderate risk criteria, but they're similar to the high-risk ones, but with values slightly less abnormal. Once sepsis is expected for primary care, the key point is to arrange rapid referral or admission to hospital. In remote or rural areas where transfer exceeds 1 hour, the guideline states that systems should exist so GPs can give the first dose of antibiotics when high-risk criteria are present. For borderline or uncertain cases, we should provide clear safety netting and ensure patients and carers understand warning symptoms and when to seek help. Let's quickly touch on sepsis in children. Risk stratification for children is a lot more complex and is based on age bands: under 5, 5 to 11, and 12 to 15. each with its own physiological thresholds. Because of the complexity, I will not go through all the high-risk criteria here, but we need to remember that severity is judged not only on vital signs, but on age-appropriate risk criteria combined with history, examination, and clinical judgment. Adult early warning scores such as NEWS2 should not be applied to children. If a child meets any high-risk criterion, they require urgent admission to hospital. For lower-risk children, we must still decide between safe management in the community with safety netting or urgent admission if concerns arise. For this, communication must be tailored to the child and the carers, with clear explanations as to what to do if the situation does not improve. Let's now move to people who are pregnant or within 6 weeks postpartum. They fall under a separate guideline because pregnancy changes physiology and the pattern of infection. For pregnant or recently pregnant people, NEWS2 is not appropriate either. Instead, we should use a pregnancy-specific table with high risk, moderate to high risk, and low risk criteria. These criteria include the usual physiological markers, but they use pregnancy-specific thresholds, and they also emphasize obstetric sources of infection such as endometritis, wound infections, urinary infections, retained products, and mastitis. Again, I will not go through all the criteria here, but NICE has produced a visual summary of the risk criteria for all groups. The link to it is in the episode description. Going back to the assessment of suspected sepsis for people that are pregnant or recently pregnant, if any high-risk criterion is present, emergency admission will be required. For us in primary care, the key points are that pregnancy or up to 6 weeks postpartum automatically places the patient in a higher risk group. We must use pregnancy-specific criteria rather than adult scores. The threshold for calling an ambulance at pre-alerting services is lower. And finally, we should always think of obstetric sources of infection alongside the usual ones. So that is it, a review of the NICE updates relevant to primary care. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.